Dr Ian Higginson, a working A&E doctor, Vice President of the Royal College of Emergency Medicine, is here with me. Good afternoon to you.
Good afternoon.
I mean, let's focus on the detail of the wider detail of what's going on. I gave sort of a brief indication of what might be bearing down on A&E departments in terms of beds and getting people out of the waiting area into a bed. What is going on from your perspective? What is happening?
So I don't disagree with large proportion of what you said. What we're seeing happening in our emergency departments is they're becoming completely rammed with patients, and those patients are usually waiting for a bed in a hospital. The hospitals are full because there aren't enough beds in the hospital. You pointed out that there's been, over the years, huge cuts in the number of beds available in this country, and we have one of the lowest beds per capita in developed nations in the UK. And also because of the difficulties in our community care and our social care systems, once patients are fit to leave hospital, it can often take them quite a while to be able to do so. So our hospitals are too small, if you like, not enough beds, and those beds are often not being used effectively because patients are in them who could be better cared for elsewhere. So when that happens, we can't get patients out of our emergency departments, so our emergency departments fill up. And then when we've found every space and every corridor and every cupboard we can to put our poor patients in who are waiting, and the waiting rooms are absolutely crammed, then we can't take them off the ambulances, and then the ambulances are in our car parks, so they can't get out to people in their homes. And the root cause of all of this is in the bed capacity of the hospitals.
And the staffing? Because, of course, beds need to be staffed, don't they?
They do need to be staffed. So if the technical word would be capacity, and capacity is about having the beds, having the staff, and then using the two wisely and as best as you can. And we know that there's a workforce crisis in the NHS at the moment. That's been slowly gathering pace. We know that there is real difficulties with the number of beds. That's been slowly gathering place. And what's really sad is, as you've said, this is a slow burn crisis that has been hitting ever plumbing even greater depths year by year. But in the absence of effective intervention by politicians, other policymakers, by health service leaders who have the power to make a difference, and that difference is either through having decent plans, or choosing to invest wisely, or choosing to prioritise the things that make the greatest difference.
And I think what you've described really well is the chain, that everything is connected. And the one thing that we haven't spoken about in that chain in any detail here is social care and primary care, because you said something that I know politicians hate hearing: the hospitals are too small, because there is this thinking that we need to make hospitals less full. We need to have fewer people ending up in hospitals in the first place by doing primary care slightly differently in some respects for older people, for people with particular conditions or disabilities, and for doing social care in a way that means nobody is ever, quotes, bed blocking. And yet that bit, social care, has clearly been politically neglected, hasn't it?
Yes, and I think that to some extent this is part of the reason for this, is because the leadership and management is inevitably short term, and because the NHS is so politicised, people are often looking for the quick, in inverted commas, or easy, in inverted commas, solutions, and aren't prepared to put the hard yards in to do the right thing. And the right thing is to look at the system in the round and work out where it's failing. And often when we've needed to save money, the easy solution has been, well, if we reduce the number of beds, then we don't have to have as many staff and we don't have to pay those staff. And so over the years, all of us have witnessed this sequential false logic of let's make the NHS more efficient. And we all know that unless you have spare capacity and you have a little bit of wriggle room, you can't do anything well. And it's running so hot now that it doesn't take much for it to fall over. And sadly, we're seeing that very frequently in, I think, almost every hospital in the country, and increasingly frequently. And one of the measures of that is hospitals declaring critical incidents. It has to be really bad for them to do that, really bad. The government have made it really hard for you to declare a critical incident.
What has to happen for that to be the case?
Well, these days you can't just say we're full, we're in critical incident. You have to say we're full plus this, plus that, plus the other, and we've done all this. And they changed the wording from, it used to be black alert to an attempt at a more standardized system. But as part of that, it became much harder to declare it. So when you see that happening, things are really bad. But the other really obvious way it shows is at the front. So the problems are at the back, but at the front, our departments are full. And then you see ambulances in car parks. That's one of the visible markers of this. But patients who come to our departments know what's happening. They can't get hold of an ambulance. They wait in an ambulance. They wait in our waiting rooms. They wait in our corridors. And they look around them and see our poor staff working really, really hard to fix all this. And invariably we hear from patients, God, how do you guys work like this every day? We just don't understand how you can cope.
If the right choices and they were acted on, if the right choices started to be made today, in your view, about bed numbers, about capacity, staffing, about support in social care, I mean, there's so much to it: ambulances, social care, primary care. What would be the most important thing to do? I mean, they're all important for the chain to run smoothly, but what would it look like, and how long do you think it would take before it made a difference?
So it's going to take years to turn this around. So there are already extra beds in the system. We've seen that they have made no difference over the last year to the way things are happening. So we need to keep on going with that. But as you pointed out, they need to have staff, and those staff take years to train and to recruit. So we need to be putting in those plans now and investing in those plans now. And the same goes for social care. There are short-term things you could do to stop staff leaving. We could look at how we can improve the working lives of staff, how we can improve their terms and conditions, and there's been some good work, for instance, done around retirement options to stop staff leaving. That can stop staff leaving to a small degree, but we've still got to keep that pipeline going, because there's also a burgeoning crisis within the workforce of many of us are getting older. And we will have to retire one day, and we need people to come in behind us to carry on doing what we're doing.
And we've heard today, junior doctors, new strikes, 4-day walkout from the 24th of Feb.
Yes, it looks like that another one's going ahead, and I think that reflects generally what's going on in the health service. We don't generally comment on the strikes themselves, but much of the industrial action is another symptom of what's been going on in the NHS. Staff are really worked to the bone, and many of them are quite demoralised because of the sort of things we're talking about.
Okay. Thank you very much indeed, Dr Ian Higginson, working A&E doctor and Vice President as well of the Royal College of Emergency Medicine.